Welcome to the Cardiovascular Review lecture. So cardiovascular physiology, a little refresher. The heart is a muscle. So the heart is an aerobic muscle that functions to pump blood through the body via blood vessels. As a muscle, the heart needs its own blood supply. Just like your skeletal muscles need blood flow, your heart needs blood flow as well, typically a lot more because it's always functioning. And atherosclerosis is a narrowing and hardening of the arteries that can lead to a myocardial infarction of the heart muscle. So it's a heart attack with no heart muscle. That's when a part of the heart does not get proper blood supply, and that can lead to tissue necrosis or tissue death. Okay, here is a drawing of the heart. One thing that you should notice is that this is the left ventricle, and you can look at the size of the heart muscle on the left ventricle versus the right ventricle. It is much smaller on the right ventricle than the left ventricle because the left ventricle generates more force. So you have your left ventricle, your right ventricle, your right atrium, your left atrium. So the atria serve as a conduit where blood flows through into the right ventricle. Then left atria contract at the very end, and then the right ventricle contracts, and that pumps blood to the lungs. Pumps blood to the lungs, and then blood returns to the left side of the heart from the lungs, where it goes through the left atria into the left ventricle. Left ventricle fills with blood, the left atria contract, and then right after that, the right ventricle, or the left ventricle contracts, and that pumps blood out to the body. And so the reason why the left side is so much larger than the right is because the left side generates a lot more force to be able to pump all that blood out to the body, versus the right side just has to pump blood up to the lungs, which is very nearby. Myocardium. As you saw in the last slide, muscle thickness varies with the stress placed on the chamber walls. And so if you have to generate more force, which you do in the left ventricle, the muscle thickness is going to be greater. The left ventricle has larger muscle mass, can develop higher pressures. With vigorous training, the size of the left ventricle can increase. So if you're a cardiovascular athlete, typically you have a larger left ventricle. And if you're a resistance trained athlete, you typically have a larger left ventricle. Due to intercalated discs, impulses travel from muscle fiber to muscle fiber in the heart, which is not like skeletal muscle. So if one cell in the heart contracts, that contraction will spread out through all the other cells, through these intercalated discs. Whereas in your skeletal muscle, you don't want that to happen. You want to be able to activate just a few fibers for a fairly weak contraction versus all the fibers for a maximal contraction. So here's a picture that compares skeletal muscle to heart muscle. And heart muscle has these intercalated discs that substances can pass from one cell to the next, causing contraction. So if this cell contracts, substances that cause this cell to contract will pass to the neighboring cells, causing these cells to contract, which will pass to the neighboring cells, causing those cells that will spread out like a wave throughout the heart, whereas you don't have that connection in skeletal muscle. So intercalated discs allow for the myocardium to act as a succinctium, so act as one large muscle fiber so they all contract together. And as far as the coronary circulation goes, the heart muscle has its own blood flow. I mean, just like any other muscle, it needs blood supply. So you have your major vessels of the heart. You have your circumflex vessel. You have your anterior interventricular artery, or left anterior descending artery. You have your marginal artery. You have your right coronary artery, and you have your left coronary artery. And if you'll notice in the picture over here, it's fairly extensive, and even this picture doesn't really do it justice because you have a very extensive blood supply going to the heart. The heart is a very aerobic fiber. It needs a lot of oxygen, and I'll show you in later slides that it typically requires more to extract more oxygen from the blood that it gets than most other tissues, even at rest. So the conduction system is comprised of the SA node, which is right here. That is what initiates the contraction of the heart. So that sends out an impulse to all the fibers in the atria of the heart. And the atria and ventricles are separated by a fibrous tissue that doesn't allow that impulse to pass through. And so the only place that that impulse can pass through is when it hits the atrioventricular node, or AV node. So you have your SA, or sinoatrial node, and then your AV, or atrioventricular node. So it receives the impulse that was originally conducted by the SA node that causes the atria to contract, and then it goes to the AV node through the AV bundle, or sometimes called the bundle of His, where it's delayed for a short period of time in this area, and that gives the ventricles time to fill maximally. And it goes down through the bundle branches. You have a left bundle branch, and you have a right bundle branch. And it goes out to Purkinje fibers, which spread out all through the heart, and this passes that conduction very quickly over the heart. Now, while the heart muscles can communicate with each other from cell to cell, the impulse travels much faster when you use nerve fibers. And if you have any type of interruption of blood supply to the heart, that can damage these specialized nerve cells, leading to conduction issues with the heart. So, extrinsic control of the heart. So, the heart can contract on its own. If you take the heart out of somebody or something, typically the heart will beat for a certain period of time. A fantastic example of this is in the original Dumb and Dumber. But also in Last of the Mohicans, they did it, and there's a few other movies where they rip out the heart and it's still beating, whatever. But it actually does do that. And that's intrinsic control. So you have extrinsic control, or outside factors that control the heart. And so you have your autonomic nervous system, which has two branches. You have a parasympathetic branch and a sympathetic branch. Now your parasympathetic branch, holy cow, predominates at rest. And the main neurotransmitter that's released is acetylcholine, which you might recognize as the same neurotransmitter that is released at the motor end plate by motor nerves, causing skeletal muscle to contract. But acetylcholine is released by the sympathetic nervous tissue, parasympathetic nervous tissue, and I'll let you know what that does here in the next slide. Your sympathetic nervous system increases activation with stress or with increased activity levels. So the greater effort you give during exercise, the more intense your exercise, the greater your sympathetic nervous system activation. And norepinephrine is the sympathetic neurotransmitter that's released. And you also have your adrenal medulla. It releases epinephrine and norepinephrine as well. And it's released from the adrenal medulla, and this is due to sympathetic nervous system. So as you increase activity levels or stress, your sympathetic nerve activity increases. That affects the adrenal medulla, causing it to release epinephrine and norepinephrine, which increases the sensitivity, or at least epinephrine does, of the heart to norepinephrine. So, specifically, the parasympathetic nervous system acts through what's known as the vagus nerve, which when you hear Vegas, you think of Las Vegas and something exciting. This is actually calms the heart, if you will. And this causes a decrease in heart rate and, to a lesser extent, a decrease in force of contraction. And this peripheral nervous system, PNS, or peripheral nervous system, dominates at rest. And so this vagal tone is what is, dictating your resting heart rate right now. If you're resting, if you're exercising while you're listening to this, then whatever. And that is acetylcholine is the parasympathetic neurotransmitter. So your sympathetic nervous system is stimulated by stress to increase heart rate. So it has a chronotropic, like if you've ever heard of a chronograph, it's a watch. So chronotropic effect, and also increases the force of contraction, or inotropic effect. And norepinephrine is the sympathetic neurotransmitter. And so as you exercise, typically you get this increase in sympathetic nervous system. You get this what's known as parasympathetic withdrawal, or decrease in parasympathetic nerve stimulation, and then the increase in sympathetic nervous system stimulation. And then once again, the adrenal medulla will release epinephrine and norepinephrine, which affects the sensitivity of the heart to norepinephrine released from the sympathetic nervous system. Now, I mentioned that oxygen supply to the heart is really important. And so in this table, what you see are the region of the body. This is splank maker. This is your digestive region, your guts, your kidney, your muscles, your brain, your skin, coronary circulation, other tissues. Most blood flow, cardiac output, oxygen uptake, but the important thing is the arteriovenous oxygen difference. And this is if you measured oxygen content in the arteries and the measured oxygen content in the veins. And so the arterial oxygen content is typically about 20 milliliters of oxygen per 100 mils of blood. And this is the oxygen difference. So this shows how much of that 20 mils per 100 mils of blood that was extracted. And if you'll notice, very low in your guts, very low in your kidneys, low in your muscles, and this is at rest. Low in the brain, low in the skin, but even at rest, your heart is extracting 3/4 of the total oxygen that it's receiving. So there's not much more room to pull more oxygen out of blood, versus these can extract more oxygen out of the blood flow that it's getting. Coronary muscle, not so much. So that's why blood flow to the heart is really important, and if it's interrupted, because you can't extract much more oxygen from the blood flow you're already getting, you have to increase blood flow. So yeah, that's kind of difficult. So there you go. Okay, so anatomy of the arterial wall. You have connective tissue that connects the vessel to the surrounding tissue. You have media or muscle. So this is a muscle. So that would be the smooth muscle in an artery that causes it to constrict or dilate. And we have adventitious, the tissue around it that connects it to the surrounding tissue. It could be flowing through, muscle or cardiac muscle or whatever. And then you have what's known as the intima, and this is your endothelial cells, and these are very important in releasing vasoactive substances that affect this smooth muscle area right here, this media. And so what's released here due to different types of stimuli will have a great effect on here. And one of the issues is as you age, you tend to have problems with your endothelial cells. So that can affect the heart. Now, development of atherosclerosis, or a narrowing and hardening of the arteries. So typically it starts with an injury to the lining of the intima. And you have platelets and monocytes that are attracted to the site to help repair the area. Smooth muscle cells migrate into the intima and divide. Macrophages and smooth muscle cells release collagen and other proteins. And the mature plaque is a collection of foam cells, protein, smooth muscle cells, cholesterol debris. The plaque can harden and crack, and the debris can break loose and damage the vessel downstream or clog the vessel downstream, all kinds of nasty things. So if you think of your vascular system as a closed system, you want to keep it closed. Now you can redirect blood flow by increasing or decreasing the vessel size through vasoconstriction or vasodilation, but you want to keep it a closed system. So if a vessel is damaged, your body tends to maybe overreact a little bit. And if you've ever seen a redneck bondo job on an old Camaro or something like that, that's what your body does inside the vessel. So redneck bondo. But anyway, so yeah, it tries to fix it and sometimes overdoes it. So yeah, so there you go. And I can do that because what happens is it decreases this area right here. So it goes from this big open space to blocking off a little bit of it right here. So you have a much smaller area for blood to flow through, and that is bad, very bad. So here's some examples on coronary muscle, blood flow being occluded or decreased. So you have a relatively unaffected vessel with some plaque buildup, and then as you keep aging with poor genetics and poor diet, you get even greater buildup and greater buildup. So you have this large opening for blood to flow through, and now it's very small. And that's really bad because blood flow is greatly affected by the size of the tube that it flows through. And so you could decrease the size of the tube by just a very small amount and cut the amount of blood flow by half. And here's a picture of a coronary artery that's, looks like bacon. That's probably why, because I ate a lot of bacon. But anyway, it's pretty bad stuff. So this is a blocked vessel that leads to a heart attack. So all the tissue that's downstream of here that's not fed by another part of, say, that vessel or that vessel is going to end up dying unless you can get rid of that clot. So this shows you the effective radius or the opening of the vessel and how that affects blood flow. So if you have a radius of, and this is just arbitrary numbers here, but just to show you an example, radius of 5 millimeters, you have a flow of 10 milliliters of blood every second. If you cut that radius down just by a short amount, you go from 5 millimeters to 4.2 millimeters, you can cut blood flow by half. So it's really important that you have healthy vessels. And we're going to finish up with EKGs. And so if you'll notice, this shows some EKGs. And I'm not going to go totally into EKGs, but what I do want to point out is there's an isoelectric baseline that everything should return to. As you'll notice, this is showing ST segment elevation. So there's your QRS, and then there's your T wave right here. So this is the ST segment elevation. It doesn't return to the isoelectric baseline. It stays above it. So it's elevated above the isoelectric baseline. You can see it in other areas right there. So there it's staying above the isoelectric baseline opposed to there where it's, right, everything's coming back to it. But you can see all kinds of bad things. There's ST segment depression right there. ST segment elevation right there, elevation. So all kinds of bad things. Here's an example of ST segment depression where it has this, it goes down, doesn't return to the isoelectric baseline right here. It stays above it, or it stays below it, I'm sorry. That's bad. That's a sign of ischemia or lack of oxygen to the working tissue. This is similar, but because it doesn't have a flat part, it's constantly sloping. This isn't really cause for alarm. So there you go. There's your cardiovascular review.